Professor Pang, you may begin.
Okay, thank you very much. Okay, good morning. Welcome everyone to the first session of day 2 of the 2021 Southeast Asia Regional Meeting on Surviving and Thriving, Innovating Through the Pandemic and Beyond. The theme for this forum discussion is Leveraging Artificial Intelligence in the Era of COVID-19. My name is Dr. Pang, and I will be facilitating this forum. As all of you are aware, COVID-19 enters the limelight at the end of 2019 and continues to devastate the world well into 2021. In order to break the transmission of this highly infectious disease, many social activities have been significantly interrupted. The healthcare industry is definitely not spared of this impact due to the requirements of social distancing. The number of patients and carers who are allowed to attend the outpatient as well as the inpatient clinics have been significantly reduced. This has affected the opportunity of patients to receive proper consultation. However, there is one bright spot, if I may say, as a consequence of the COVID-19, is the adoption of digital technologies has suddenly accelerated. I believe this trend will not revert in the post-pandemic era. We are expected to see continuous growth and innovations in this field. The question now is, what is the best way to embrace these technologies in healthcare, and how do we leverage digital technologies, particularly artificial intelligence, in healthcare? In today's session, we will hear from Association of Academic Healthcare and international members in Indonesia, Malaysia, Singapore, and USA. So before we begin, I will introduce all of the panelists. There are 4 panelists altogether. The first one is Professor Chronic Paul Michael. He's a physician and a global health specialist, and is the Deputy Director of the Sing Health Duke NUS Global Health Institute. Dr. Chronic has published widely across a wide range of disciplines, including health systems, data and analytics, digital health, communicable disease control, gender-based violence, child health and nutrition, water and sanitation, social capital, and public health ethics. The second panelist is Prof. Gilan Al-Sadawi. Is an experienced practicing pathologist with a comprehensive background in research and academia. Gilan is a former CMIO at the M model, where she led development of NLP solutions used at over 4,000 healthcare facilities. Gilan received her MD and PhD in pathology from Ain Shams University in Egypt, as well as a master's degree in medical informatics from the University of Pittsburgh. The third panelist today, Professor Dr. Daniel Tanda, is a lecturer, researcher, and international pulmonologist. Is currently the internist at the Division of Respiratory and Critical Care at the Department of Internal Medicine and Faculty of Medicine in Universitas Indonesia. Dr. Cipto Magun Kusumo National General Hospital in Jakarta, Indonesia. He currently serves as a head of the Artificial Intelligence and Digital Health Research Group at the Indonesia Medical Education and Research Institute. And then the fourth panelist, Dr. Ki Yuan Niam, overseeing the technology deployment in Singapore's Western Healthcare Cluster. Is also an associate professor in the Department of Surgery at the University and Deputy Chief Medical Informatics Officer at the National University Hospital. Dr. Niam's focus is on artificial intelligence research and implementation in healthcare, as well as endocrine and metabolic surgery. Each panelist will be given 10 minutes for their presentation, after which we will have a facilitated Q&A session. For the audience out there, you can type your questions in the chat box, and we will deliver your question to the panelists at the end of their presentation. So with that, I'd like to invite the first panelist to give a short presentation. Prof. Pronik, is yours on the screen.
Thanks very much for the introduction. Really interesting panel, and really good to be with you this morning talking about this critical issue. I'm talking to you from Singapore, from the Sing Health Duquesne US Global Health Institute, but I'm actually going to be sharing experience from Indonesia, where I was the leading UNICEF's health, nutrition, and water and sanitation programs for the past 5 years, and was really heavily supporting the COVID response. And just talk a little bit about some of the lessons that we've learned in that context that are relevant to the topic today. As Dr. Pang was suggesting, the past decade has really witnessed nothing short of a renaissance in digital health innovations. Blockchain technology provides highly secure ledgers, mostly used for finance, but with serious applications in the healthcare industry. Big data such as locations and search queries and social media content, stuff that really was only available to advertisers even 3 years ago, is now being used widely for social good. Satellite images can now be downloaded for free and used to monitor changes at the human and environment interface through AI technology. And low-cost smartphones, as I'm sure all of us know, can provide real-time information to from individuals and families direct from users. And as Dr. Pang was saying, a lot of these things are really in their infancy, and because of COVID-19 and because of the necessity of working remotely, there's been a real acceleration of progress in applying these new tools to how we do business in healthcare. Now, early on in the COVID response, even 6 months ago, just kind of pre-Delta, people thought that Southeast Asia was somehow relatively successful in controlling COVID-19. But in fact, emerging data from sero surveys, so looking at population-based samples and antibody testing, actually suggests that Southeast Asia is the most highly COVID-infected region in the world. And COVID is difficult. It's not like Ebola, where 80% of people come down with symptoms and they're visibly bleeding in front of you. In most cases of COVID-19, as everyone's aware, there are few or no symptoms. For every sort of 2 sick cases, there's at least 8 people who've been infected who are not sick at all. And this makes COVID elimination strategies exceptionally difficult. And it's really something that we only try in very well-resourced health systems with very well-controlled borders. So most countries have to opt for COVID suppression strategies and population-based interventions. The question then becomes, what data is there to help policymakers and practitioners introduce these policies in ways that make sense? Suppression strategies need to be informed by evidence. And in many low and middle income countries in Southeast Asia, that evidence isn't there. That data is just not there in a timely and reliable way. There's very few systems to track transmission and behavior. Testing data is often inadequate, and when it does erupt relative to other countries, Southeast Asia is 30, 40, 50 times lower than, say, the United States or Europe in terms of testing levels per population. In Indonesia, where I was working, the time between doing a test and reporting a result, could be 2 to 3 weeks, right? There's often inadequacies in hospital data, often getting data from the public and the private sector into a single system is extremely challenging. And there's also major issues with vital events reporting, so death reporting. So if policymakers are using ICU cases and deaths as the only data points to inform when to loosen or tighten restrictions for COVID-19, you're going to be anywhere between 3 and 6 weeks behind the transmission curve. So the question then really becomes around how, if policymakers are kind of flying blind, how can we use digital innovations and all of the advances that I've mentioned to try and help us make more effective and more timely decisions? So in Indonesia, we were able to work with, through UNICEF headquarters, our innovations team, working directly with Google and Facebook to try and get access to big data to try and help us inform some of these decisions. The Google data particularly comes from Android phones, and Facebook comes from websites as well as phones. And Indonesia's got some of the highest Facebook utilization rates in the world. About 140 million people use Facebook. And this provides anonymized aggregate data on a daily basis that can be visualized all the way down to the village level, accurate to about 50 meters of where someone is. And you're able to generate metrics such as where someone is during the day versus where they are at night. Of course, it's done anonymously to respect privacy, but it gives you a sense in terms of whether people are able to stay at home, and if they're moving, where are they moving to? And this is quite important to try and help us understand whether, for example, stay-at-home messages or work-from-home messages are actually being adhered to, and where they perhaps need to be intensified. And in Jakarta in particular, we were able to link this data to case detection to try and look at the effects that this was having on transmission. So very quickly, this graph on the left charts two things. The blue bar is the percentage of people that stay at home, and the red is new daily cases. And basically, this is data from all of 2020. And what you can see is that as cases increase and policy restrictions are introduced, say at 0.1 or 0.1, for example, you see an immediate flattening of the curve. And then as restrictions start to be reduced, we see transmission increasing again. And then restrictions were reintroduced, cases came down, and so forth. And what was interesting and important about this mobility data is it was able to provide us, it was able to basically predictive of COVID-19 7 days in advance of actually seeing the case numbers. So, as we see the reduction, the people not staying at home anymore, 7 days later, you'd start to see that increase in transmission. So really, really kind of important, interesting data there. We also were able to kind of look at this using AI at the community level to try and understand what this means for households that are wealthy versus households that are living in much poorer environments, such as urban slums. About a third of Jakarta lives in some sort of urban slum type conditions. And the way artificial intelligence and remote sensing can do this is it can look at housing construction effectively and try and identify, very, very quickly whether or not some areas are poor areas and some areas are wealthy areas. And this is tough. I mean, Greater Jakarta has got 25 million people. The dynamics in urban slum populations are quite serious. Doing detailed socioeconomic surveys takes a really long time and is quite challenging. So these AI tools and devices were able to tell us that, yes, it was really just the wealthy areas that were able to stay at home. But for poor folks, what does stay at home mean when you've got to do piecework and, you're just very close to the sort of poverty threshold and you just don't have that kind of option. We are also able to look at it by overlaying what are called shape files, which gives you, like the GPS coordinates of every village or district or what have you. The blue part of this map is people who are able to stay at home in Jakarta, so it goes up to around 70%. But you can see that poorer areas around Jakarta are persistently red, where where people just aren't able to stay at home, and we know very well that there's a lot of movement between these areas and the central parts of the city, where a lot of folks come to work. And this data was important for the government. It was important for policymakers because it helped a more effective targeting of social protection programs, such as different sort of food subsidy programs, unemployment insurance, cash grants, grants to small businesses. And it was really able to kind of target some of those areas where people were really having a difficult time staying at home. The other innovation that the government introduced through UNICEF support at the time was real-time monitoring of behavior. In particular, they did something called the 3 M's, which is mask use, social distancing, and hand washing. And we had volunteers with smartphones in different locations, just sort of monitoring what folks were doing, and then using simple SMS-based systems to send that information on a daily basis into a dashboard, basically, which you could then visualize and feedback to folks. And it sort of looks like this. It can sort of tell you, what proportion of the population are actually adhering to these safe behaviors, and where additional intensification needs to happen. And you would have the cell phone numbers of the district leadership and the mayors and so forth. So that would automatically get fed back to them on a daily basis to say, hey, in your district, folks aren't really adhering. We need to look at other strategies and other approaches. So in summary, innovations in the use of big data and real-time monitoring with AI allowed for really novel ways of addressing COVID-19. And it was really great for me, in UNICEF, particularly working at a global level, to see Indonesia's leadership in this space. The systems that were developed in the country were scaled widely within the Southeast Asian region to support other governments doing similar things. And I think in terms of next steps, some of the things that are going to be quite critical and important to understand is how do we take these kind of new tools and new technologies and use them in a way that is kind of complementary to how we use health data conventionally, which is household surveys and health facility data and so forth. So it's a whole new era of opportunities here, and something that we really need to explore, not just for COVID-19, but for routine health services moving forward. So I think I'll stop there, and thanks very much for your time today.
Thank you very much, Prof. Michael. I think we will go to the second panelist presentation before we go for Q&A. I think we'll leave the Q&A at the end of the presentation. So the second panelist, Prof. Gillen. Okay, you may take over the screen.
Okay. So actually, I'm so happy with the first speaker, Professor Paul, because he looked at the problem from a population level. What I will do is actually take it into a patient level. So we are a portfolio company of University of Pittsburgh Medical Center. That means we operate within the system and try to use the technology we have to help the system face the problems. And as Paul said, the data is big. There is a lot of things. The technology that we're using, or AI in specific, is to actually explain the sum of all the structured and unstructured patient information. So we were not looking at a population level, but actually, how can I help each and every patient that comes into our system? Can I prioritize the patient to benefit from a specialized care? Can I intervene before they become a high-cost patient? One of the problems of the COVID is all of these high-risk patients coming into the hospital are at a higher risk of getting infected. So can I optimize the care for them without bringing them into the hospital? So I'm sure all of you know what's AI, but what's different in the way we tackle the solution is, in addition to using of the artificial intelligence or machine learning, we actually build what we call information models. These information models collects the information from all the structured or pieces of information and unstructured, which is the narratives of the patient that the physicians write. One of the problems of the COVID is, yes, in our EMRs, we actually captured discrete data elements, but we didn't capture the discrete data elements that define this is a patient that has COVID. That's why it took us a long time in order to identify these are the signs and symptoms that tells me that this patient has become infected. So the idea of using artificial intelligence to build a patient story where I define all of the clinical models and actually define all the signs and symptoms. So at any time when a new sign and symptom appears, I don't have to start from scratch and I don't have to train my EMR. This is a detailed architecture of our system, how it works. So we start with all the patient notes, all the EMR data, then we actually identify machine learning and NLP and map it to standardized normalized ontologies, the most common of which is SNOMED, and it is national or international. Actually, it's not just a US version. And then we build this patient level understanding. We understand the models of all of these clinical conditions that the patient have, and then we release it either to the original EMR, to our application, or even, as I will show, something as simple as a spreadsheet that can be used by the clinical personnel. The problem we saw during the COVID era is not the lack of the healthcare data. It is the accessibility of that data. The data is completely buried in the narratives of the physicians, the narratives of the nurses, and completely disorganized. The data is missing context. So it took us a while to figure out that the loss of sense and smell is actually due to the taste and smell is due to COVID, because this was buried in the narrative data. We couldn't capture that until sometime and after a couple of months to have enough data to actually say that these are signs and symptoms. So the challenge we had, or what we started to do, is we had one of our family health centers is St. Margaret, and it is like servicing around 12,000 patients. And these 12,000 patients are high-risk patients. That's to say they have a lot of chronic conditions. Some of them had cancer, and we needed to identify these high-risk patients based on their demographics. One of the things that Paul said is where you live, and in the United States, the zip code would tell you if you are in a wealthy or unwealthy. Unfortunately, that's not only the indicator, because as what would happen with COVID, a lot of people lost their income. There was a lot of socioeconomic factors that affected how these patients have been living, or getting enough food, or even having accessibility to like someone to drive them. So we needed to free the UPMC hospital resources to focus on the COVID-19, and we needed to find a quick way to look into the charts and understand the patient risk. Usually when we care for the patients, we look at it from a population, right? That's the major way, exactly like Paul said, to get the policies out. We look at a population level. But in our case, we needed to change that population level into actually individual patients. Can I identify who in these patients that I need to go quickly and reach out, whether due to their chronic conditions, their social needs, or demographic? And can I prioritize my outreach? So I have a very few resources in the hospital, physicians and nurses. Who should I call first and track during the pandemic? Okay, as I said, it's all in the unstructured notes. So we needed to use artificial intelligence or natural language processing. What we did is actually we took all of the EMR data, passed it, whatever we had, whether it's EMR in a registry or in population reports, passed it through the technology, which is AI, and did a prioritization list. Who should be referred to a specialist, who should change care, and who should be prevented from coming to the ED. And this example, the approach we did was very quick, very easy. We had a document management system that collects all the documentation from across the whole system. It's 35 sources of data. It's a big system that we have, 40 hospitals and a lot of outreach, but we started only with the St. Margaret as in our proof of concept. We started any patient that had an office visit in the past 3 years. So we said, if that patient came to us in the last 3 years, probably he has a condition that he's following up with. Then we prioritized the report based on demographics, over 65, he is living alone, there is certain conditions, and we generated a simple Excel spreadsheet just to overlay the EMR. The patients had utilization, so if they came to the ED, if they were admitted to the hospital in the last 3 years, and if they are a recent discharge. And then we looked into their chronic condition and things that can make them high risk for COVID, like they are on an inhaler or they utilize oxygen therapy. And of course, we focused on the people that has social problems like living alone or food insecurity, right? And we gave the team, the clinical team, a very simple Excel spreadsheet that had all of this clinical data like in columns, and we gave them the flexibility to actually pick and choose every day based on the number of resources to have to prioritize the patient. So for example, today I don't have many people that can reach out to patients, so I'm going to focus only on the highest risk patients. Tomorrow I have 10 people that can pick up the phone, so we can relax the criteria, right? We did calculations only for 4 weeks, from the March 29th to April 26th. This office or this clinic was having 12,000 patients. As I said, they were identified by any patient visiting that clinic in the last 3 years. And then we identify only from the 12,400 that 1,500 patients that needs to be reviewed based on our criteria. Actually, the offices only reviewed 500. They attempted outreach of 71%, leaving messages or trying to send a letter or send a UPMC representative. And they did a contact of 50% of the patient, right? And made intervention of follow-up for some of these patients. Some of the examples of the follow-up, like you don't have to come back to the office to get a refill or adjustment of your medication. If I needed to refer a social worker so that it visited them at home, if we need telehealth and unspecified follow-up. Another thing that the digital health has shown a value is the use of telemedicine. Like it's been, and it is not decreasing, as Paul said, and the digital health is here to stay. So one of the things is the telemedicine visits. So we said, okay, did we make a difference in the number of telemedicine visits in our office versus a regular office? And although both offices had a high level of telemedicine increase because all of the physicians were like moving their patient into telemedicine, what we found is that the engagement in the telemedicine was with a higher risk patients in the office that started this practice. So although yes, it's the same telemedicine number, but they were actually focusing on the patients that needed this telemedicine. Another thing that we found are things that, like anecdotes that you can tell that the system is working. Someone avoided coming back to the ED because they fell and they were trashed in place. Not coming to the ED at this point freed our hospitals for the COVID patient, and at the same time decreased the incidence of that patient of getting ill COVID. Other things is like from the social like determinants, they could actively stop a suicidal patient and connected them to behavioral health. So we could see that there is an effect. From now on, from then, now for a year, now we have an active system that's up and running, that has an API with a simple user interface that they can actually track their patients, they can highlight. The nice thing about the technology or AI is actually you can see why the system has recognized that patient as a high-risk patient. You can go in and look at their documentation in a few seconds, right? So the idea of using the digital health or the AI is to expand where the EMRs or the EDWs stop. I don't see that this technology is going away. So AI has worked in the COVID, but you can now tell it can help in the care, in the analytics, in population health quality, and even in revenue cycle. There is a lot of places where the artificial intelligence, once you understand that patient story from the documentation of the patient, you can actually identify all the patient care need and help in research and managing of these patients. What we think the solution is a clinical focus. So machine learning and clinical knowledge influence for the machine learning. Just taking the structural notes and making an AI or a machine learning algorithm is not the only solution, unless it is influenced by the clinical that gives you a patient level understanding, and of course, adding the real time. Population health is always good and it gives you a look into the future, but at the end of the day, you need to reach your specific patient. Thank you.
Okay, thank you very much, Prof. Gilan, for the very nice presentation. So we'll now move on to the third presentation by Professor Daniel Tender. Prof. Daniel, it's yours.
Oh, sorry. There you go. All right. A very good morning to everyone. Again, my name is Eric Daniel Tender. I'm very, very happy to be and also honored to be one of the presenters and panelists for this special event. I'm representing the Faculty of Medicine in University of Indonesia, and I would like to also give a bit of a perspective and our experience in how to leverage the AI use in the era of COVID-19. But I would like to give a very good acknowledgement to the previous speaker, to Professor Gillen and Professor Paul. I think my talk will be the conclusion of both speakers. But let me start with the introduction. So this is a very nice presentation from the Vice Minister of Health of the Republic of Indonesia during the event at our institution. So as you can see here, the cause of death, this is a cohort research data for the cause of death because of a non-communicable disease. In Indonesia, during 1990, we can see the cardiovascular disease and cancer is actually taking up the first and the second cause of death. But it's actually changed, not even probably 20 or 30 years after that. So cardiovascular disease and cancer is still the top two cause of death in Indonesia. But specifically for tuberculosis and lung infectious diseases, it's now actually go down to number 4. And number 3 is actually non-infectious lung diseases. So disease like COPD and other non-infectious lung diseases actually now taken into the top 3 cause of death in Indonesia. So this is a burden of disease that we are currently facing in Indonesia until 2020, where we all need to fight with COVID-19. So these are the changes of the cause of death based on the cohort research data for non-communicable disease. And currently in Indonesia, the research and development for screening and program in the primary care, especially for patients with suspected cancer, especially lung cancer, and also other respiratory diseases, we still use a chest X-ray. So we all know that based on the research in the past probably 20 or 30 years, patients suspected with lung cancer, we need to use a low-dose CT scan. And this is what us as a physician in Indonesia, we would like to actually keep pushing to the government to take more a serious step in terms of doing a research and development for screening tools that should be used in the primary care settings. So currently the research and development, as I said before, we still use the chest X-ray, but most of the referral hospitals, we already use chest CT scan to actually screen patients with COPD to actually know before the exacerbation, and also to well grade the patients before the patient become deteriorating. So as mentioned by Professor Gillen, my presentation will be more focused on how we actually optimize the patient selections. First for the clinical outcome and also to improve the quality of life, but I will also touch base in COVID-19. So most of the lung diseases patients and all the diagnosis has been made needs based on the medical imaging diagnostic and also clinical pathology diagnosis, which we also know this two assessments is often based on the background educations of the rater, of the reader, the background experience of the radiologist, the clinical pathologist, and also other healthcare workers. And most of this assessment sometimes is very, very subjective. And we cannot afford to be subjective at this era because we need, again, as I mentioned on the previous slide, we would like to actually improve the patient's quality of life. And we need to be very, very objective in how to determine what is the best diagnosis for the patients in terms of the treatment and also for the alternative treatment if it's possible at your center. So here are the AI in respiratory medicine that we are currently doing in Indonesia. And it will be highlighted in red. So as we know, the AI in respiratory medicine is very, very advanced in terms of the development in the past 5 years. We already know that there are computer vision for disease severity for patients with COPD, as mentioned, like quantitative CT that can also measure lower volumes at the lung volume at the lower level. Second, there's an AI software that we currently use for tuberculosis, especially in rural areas. And also there's a development for predictive models in pulmonary hypertension, asthma, pleural infections, and pulmonary function tests. As I mentioned to you, that's what we call quantitative CT. And also there's an AI development for pulmonary fibrosis. And last but not least, we have the AI to actually help the physician and clinician to have a quick screening diagnostic tools for COVID-19. So at Faculty of Medicine, Universitas Indonesia, we're currently doing 3 of this AI in respiratory medicine. There are still ongoing trials, and hopefully we will publish it soon. So as mentioned by Paul, the first speaker at this panel, I think you mentioned about one of the ongoing research that we already use together with the government to see the movement of the population. And this is what we call Sinergi Mahadata Fakultas Kedokteran Universitas Indonesia. So we are managing a big data to actually, as mentioned by Paul, to actually monitor the movement of the people in a certain areas of Indonesia. And this is very, very helpful, and we are actually very, very glad that one of the ongoing research in our research group already been used and utilized by the government to actually combat the COVID-19. The second one, I'm glad to share one of the fast-track development of the AI detections of COVID-19 based on X-ray images. This is what we call the COVID-19 study. So the COVID-19 study actually comes from a discussion from the experts how to actually tackle this 4 problem. First, at the beginning of the pandemic, it will take a much longer time to actually get the RT-PCR results. Second, we need actually to establish the diagnosis in time, because let's say in my hospital, the National General Hospital, we are actually bombarded by the patients. We actually get a lot of referral from the sister hospitals. So we need to actually establish the diagnosis as soon as possible in order to separate the patient and classify it in time. The third one, after the patients get better, we also would like to know how many beds are actually occupied and whether the bed occupancy is actually for the COVID-19 patients or not. Due to not be able to examine in time, then we are actually, that time we are facing a very hard time to actually managing the beds. So again, if you're talking about the RT-PCR, especially for the nucleic acid testing, the false negative problem is still that have still raised at the beginning of the pandemic, and also for the specimen collection. So on our nation or our local guidelines at the hospital, we actually established that if we can actually base the diagnostic approach on a clinical imaging and lab testing, that will be excellent for the patients. That's why we come up with this study in collaboration with Delft Imaging to diagnosis based to establish the diagnosis for patients with COVID-19. So we use a CAT for COVID, which is an AI algorithm that will generate a score between 0 to 100, indicating the extent of COVID-19 in related abnormalities for patients with suspected COVID-19. We are currently in the end of the study, and I can actually share the one of the analysis from the ROC curve is actually looking pretty good, and hopefully we can publish the data as soon as possible, as soon as we finish. The third one, this is beyond the pandemic, and we also know that Indonesia is still on the number two countries with the highest populations of tuberculosis. So in order to combat tuberculosis as well, we are in collaborations with Delft Imaging to actually implement it, a chest X-ray based detection for tuberculosis patient, and this is already running in a few centers, and we are currently also doing in few centers in Indonesia, and we are in the midst of completing the data. As I mentioned to you before on my third slides, we are actually also in collaborations with Imperial College London to actually continue one of the my project for COPD. As you know, Indonesia is still facing the non-infectious diseases as much as COPD. So we would like to actually know the patient's condition at the earliest. So by using a quantitative CT for COPD and emphysema, we are actually hoping to give this data to the Ministry of Health to actually implement what is the best approach to tackle this problem in the future. Especially by Professor Gillen, one of the advantages, I think, after this COVID-19 pandemic era, we are actually try as much as we can to give a better service to our patients. Most of our chronic patients, they cannot come to the hospitals due to their local restriction. So that's why we actually make this research which combine integrated electronic medical records with telemedicine. The application's name is Telmed, and hopefully we will be closing this research as soon as possible. And we'll in collaborations with University of Indonesia to actually implement this application at the whole Indonesia with Telmed Box. I think the digitalization and clinical data, and also, as mentioned by Professor Gillen, the electronic healthcare records used together is the road to value-based care, especially for personalized treatment care for the patient. And of course, this will implement this shift in reimbursement climate and lifetime cost of treating patient, and stability of hospital-based care in chronic disease management, as I mentioned, like COPD, and also in a viability of remote patient monitoring that makes the right time for us to actually utilize both electronic health records, data analytics, and artificial intelligence to approach how to best care our patient, and also to identify patients who are at high risk and high cost. I will close this presentation by saying the AI will not replace doctors, but instead it will augment them, enabling physicians to practice better in medicine with greater accuracy and increased efficiency, as mentioned by Benjamin Bell. Thank you so much for the time.
Okay, yeah. Thank you very much, Prof. Daniel, for sharing the exciting projects that is occurring in Indonesia. We'll move on to the fourth speaker of the day. We'd like to invite Prof. Niam from Singapore to present his talk. Prof. Niam, the screen is yours.
Yeah, hi, good morning, everyone. Thank you for inviting me and to share in this particular session. I'm Professor Yam Kian from Singapore. I'm from the National University Hospital in Singapore. And today I'm going to talk a little bit about the healthcare AI deployment in Singapore. So before I start, I'm going to have a bit of a background slide on the landscape of healthcare in Singapore and some of the AI use cases that we have deployed in Singapore. So as you know, Singapore is a very small country. We have over 5.8 million people in Singapore, and there are about 96,000 healthcare workers working in over 8 public hospitals, as well as 26 public and private hospitals combined. as well as 2,991 primary care sites. So the kind of challenges that we face are not dissimilar to the challenges that have been brought up earlier in this discussion. So we face the same issues of aging population, increasing chronic disease burden, slower workforce growth, and rising healthcare costs. So to address these issues, the Singapore government has decided to implement a three shifts, three beyonds in terms of the healthy living master plan. So first beyond is to move beyond hospital to community to enable Singaporeans to receive a more appropriate care in the community and closer to home. Next, we want to move beyond quality to value to give every Singaporean the best value while keeping our system sustainable, and to move beyond healthcare to health. So this is moving upstream to help and support Singaporeans to live, to lead healthier lives. So to do that, one of the key strategies is to use digitization to enable the new next generation services to be deployed. And we want to make, this is a speech from our Prime Minister, to make Singapore an outstanding city to live, work and play. And this is encapsulated under the Smart Nation initiative in Singapore, where the three pillars of digital economy, digital government, and digital society are the building blocks for us to deliver better care at every level. So we are also part of the ASEAN Smart Cities Network, where we have a collaborative platform to share common goals as well as sustainable urban development. And some of these national smart health initiatives were actually shared across ASEAN at the beginning of the pandemic as well as currently. So going digital, as I mentioned earlier, we have a national health record system. So a national electronic health record system that is captured in totality with the whole of country. We have Health Hub, which is our healthy living portal, where we can use an app to access health and health related information. The pandemic has triggered a widespread adoption of telehealth. So we are moving towards home-based elderly monitoring systems, of course, video teleconsultations, telerehabilitation, and vital signs monitoring at home. There are initiatives to have a health marketplace where we can match the nurse service and supplies in the community. In the acute hospital setting, there are initiatives in smart wards and smart logistics so that we can improve the way we operate efficiently in the future. Of course, a hospital operations center like the one you see below is a dashboard and a graphical interface for monitoring hospital operations as well as video analytics. There are robotics kind of initiatives where then we have established what we call a robotics middleware framework, as well as to allow multiple robots to communicate with each other, as well as autonomous mobile robots, as well, and on top of that, assistive robots to help nurses move and transport patients. Of course, all of this is dependent on having artificial intelligence on the background. So the kind of projects that we've seen earlier, image diagnosis, chatbots, and many other AI tools that we will describe later. So like I mentioned, Health Hub is a one-stop mobile app portal for Singaporeans to access a wide range of health content, awards, and e-services. It's designed to empower Singaporeans to take greater ownership of their health and fitness, and there are multiple programs here you can see. So to dovetail with that, we actually have a app that allows patients to do things like appointment booking, registrations, payments, and education materials for patients, as well as to self-monitor their health, such as using app to use for glucose monitoring as well as blood pressure monitoring. Now, all these are front-end services that we provide to our patients, but it just gives us the ability to reach out and recruit patients into a back-end system of using AI to optimize the health of our patients. So specifically to the use cases in COVID, so we have built things like chatbots that allow people to chat with their patients, automatically to answer their questions on AI and on COVID and other related questions. And this particular one is designed for hypertension and high cholesterol. Telemedicine is something that's been around, but what I'm trying to point out here is that the back end of the telemedicine is actually an AI tool that is able to automate and match the optimal appointment times for our patients. So in Singapore, we use a Trace Together app and token to track patients. So this is a way in which we can collect large amounts of data in terms of epidemiology and population spread of COVID. So I want to change tack to talk a little bit about how we capture and use all this data. So one of the key points here is that all the data that we've captured are actually streamed through the electronic medical record in standardized formats that were brought up earlier. So things like SNOMED, RxNorm, ICD-10, etc. So these data are passed through our electronic medical record system. In Singapore, we have two large electronic medical record systems in operation today. And that data is streamed into this platform here called Endeavour AI. So Endeavour AI is where we stream real-time information through. And what we'll do is that all the AI tools that are meant to calculate and give an output are mounted here in Endeavour AI. And this data then is sends alerts to the clinicians in real time. This is in by the second to the patient, to the clinician, as well as to alerts to patients that that directly impact their care. At the back end of this is another platform called Discovery AI, which we have been operating now for about 4 years. This is where the data gets de-identified and stored here for the purposes of building and training AI tools. So we have multiple AI tools that have been trained here in the last 4 years or so. So we have things like diagnosis predictors, readmissions predictors, and disease progression predictors. These tools, when they are trained, we uplift them into Endeavour, where it will then will then consume the data that's streamed through the electronic medical record system and sends alerts to our patients. The top layer here is something called the Healthcare Commercial Cloud. This is a new development where we are starting to move some of our services and interactions with enterprises on the commercial cloud. That is commercial clouds such as Azure, AWS, and GCP. So this opens up the possibility of interacting and working with industry, as well as other partners that come on board to join to participate in events such as Datathons and Expo. So here we have anonymized and public data sets where you allow people to use the data to build models and answer questions. So at the end of this month, we will be having a Singapore Healthcare AI Datathon and Expo 2021. I can send some information later, where the data here is made available for teams to try out their AI models and their machine learning models to solve specific problems. And because this is interacting with the internet, whilst these two other layers are not interacting with the internet, we are able to control how people use this data in a fair and secure manner. Just a bit of a detail here with regards to how we set up our system in Endeavour. So the data is using a Kafka data stream. So this is the way we enable large-scale deployment of multiple AI modules at scale, consuming all the data that we have in the healthcare system in real time. So you can see here that data is streamed through things like demographics, visits and encounters, lab, radiology, images, so on and so forth, and other multi-source data, finance, and so on and so forth. So when we build this Kafka data stream, we will then we can then build microservices on top of them. So microservices are specific AI tools that we have developed so that they can output specific functions into service applications. So for example, if we have a chatbot service that consumes some of the information about the patient, we are able to output that data into, for example, a patient app where it can remind and trigger and remind a patient to, for example, take their medications or impute their vital signs information. And other services such as AI image analysis that when triggered will be able to output a particular radiology or pathology AI report to the clinician. Again, none of these are new. For example, the radiology AI has been functioning for the last 2 years or so at this point. So some of these are quite recent, like the chatbot, conversational chatbot services are quite recent, because chatbots are actually quite difficult to develop, or rather advanced chatbots are really quite difficult to develop. So some projects that we have done in the past couple of years. So this particular one looks at free text reading. So we call it Augurium. So what it does is it reads free text and it gives a diagnosis. So this one is designed to optimize for appendicitis. So it tells the doctor what's the risk and it correlates the final result so that you can retrain the model. So this high-level schematic tells us of how modern AI tools work, right? The ability to predict and also to retrain itself in a version manner is a characteristic of a modern AI tool. So how it looks like here is quite similar to some of the things that were shown earlier. So it highlights specific semantic phrases about what constitutes the diagnosis. So this particular one predicts positive for appendicitis because of these phrases that are used in the text. Again, this is an NLP type tool that is we have been using for a while, and we've completed a randomized trial that we would like to publish very soon. So of course, there are 30-day readmission predictors. So we use all sorts of data from the patient to predict 30-day readmission risk from the point of discharge. We have a disease progression modeling. So this particular one is done for chronic kidney disease to see how they will progress between the stages of chronic disease. So this is a mock-up of how it looks like. So we have the GFR value, which is the kidney function value before a cut point. And at the cut point, we are able to predict 40 weeks forward what is the risk of the patient's GFR deteriorating with time. This last model that I want to share is a neural network model architecture to predict breast cancer using free text. So this is not based on the traditional Gale or Klaus model of breast cancer. This is any free text, any categorical information, any numeric information is processed by a NLP tool. Here we use a BERT encoder and transformer to read the free text. And finally, you predict breast cancer or non-breast cancer. So this is some early results that we have. What it actually does is that it does cancer enrichment rather than actual cancer screening, because this is not intended to be a screening tool. It's intended to be a enrichment, population level enrichment tool to help clinicians select patients for mammograms. Now, the idea of selecting patients for mammograms is a very new and foreign idea, because screening is typically done at the population level. But even at its best in Singapore, we only can achieve 20% screening rate. So to increase that take-up rate, we are going to use this population level model to increase the number of patients picked up at every visit to the clinician. And the AUC today is at 0.789. So we have still some ways to making it good enough. And lastly, I want to say that I shared some of these AI advances in an article that was published in ASEAN earlier this year. Late last year. So, and this talks really about the kind of some of the models that I described earlier, as well as some of the opportunities we have, especially with the use of AI chatbots. Okay, with that, I thank you very much for your attention.
Okay, thank you very much, Dr. Ngiam, for sharing what is going on in Singapore. I think it's certainly exciting to see that actually many things are ongoing. So after listening to all the panelists' presentation, you can see that the technologies, the digital technologies are thriving well and growing rapidly in the region. Big data are being collected in many countries with the analytics in the background and the utilization of AI. I think many wonders may occur. So we have also heard how AI is likely to be a great helper rather than replacing the role of the healthcare providers. So I would like to open the session for Q&A. I think there are already some questions typed into the chat box, but in case you actually feel like asking the question directly, you can also unmute yourself. Let me just ask this first questions typed here by Prof. Sanjay Karampa from University Malaya. Okay, referring to the first presentation by Paul, there is a time lag due to time between exposure by mobility and symptom onset, so-called the incubation period. And then the time between symptom onset and testing. And the third is the time between testing and reporting. So in the 7-day time lag between mobility and case reporting, is it sufficient to account for the time between exposure due to mobility and the incidence of the disease?
Yeah, thanks for the question. I mean, I think it happened to be 7 days in Jakarta, but I think the more important point is that in the absence of this data, all you've got, if you're a manager or a policymaker, is cases detected, hospitalizations, ICU beds, right? And we know, as you're suggesting in your question, there's massive delays in terms of between testing and results reporting. There's also massive under-testing. In Southeast Asia, again, as I was saying earlier, levels of testing relative to, say, the USA, which is not by any means the gold standard, sort of 10, 20, 50-fold lower rates of testing per person, right? So, and then in poor countries, getting to the hospital's hard. Hospital records aren't great. So hospitals, private, public doesn't communicate to each other. So each link in the chain, the data gets poorer and poorer. It doesn't really help decision makers. So the reason that we did this work in Jakarta is because Jakarta had the best testing rates of anywhere else in Indonesia. And it happened to be that it was predicted with that 7-day window, which is the time, as you're suggesting in the question, to make up for transmission, incubation period, reporting, and testing. But if you did this in more rural areas, it would be much longer, right? And the other thing that's important to say is that even in Jakarta, we did a sero survey in earlier 2020, and you know, the numbers of reported cases versus people actually infected was about 10 to 1. So actual testing rates under reflected the actual number of cases by about 10-fold, right? And that's the best case scenario in Indonesia. So these ways of trying to understand, using data innovations to understand what happens earlier in that whole cycle is really critical in terms of trying to make effective decisions. And one reflection too, if you allow me, I think these presentations are really interesting because you go all the way, again, from the population level to what you're doing with electronic medical records to how you're managing individual patients. In terms of the last presentations in Singapore and through radiology and CT scans and so forth. And what's going to be really interesting is how to bring these systems together, right? Because you're going to be able to ask questions of your health system in ways that are really unprecedented, in ways that I can't even imagine. But stuff that you could do is actually really exciting. And healthcare is something that's ripe for disruptive innovation. People don't want to go and sit and, you know, travel 50 kilometers, sit in a doctor's office all day, you know, to have something that could be done with a quick telemedicine consult. So it's kind of analogous to what happened, you know, 10 years ago, waiting in line at the bank, then waiting in line at the ATM. Now you do everything by the internet. So healthcare is going to be in that same situation, and using data to understand, prepare for, and effectively implement those changes is going to be quite critical moving forward.
Okay, I have a question here. I think the panelists have mentioned that, well, I think we are collecting actually a lot of data using actually the computer, mobile phone. So it is interesting how much actually we can get from the data. In fact, someone put it this manner: data is the oil of the 21st century. So it's worth a lot of actually money as well as value. My question here is, many countries in Southeast Asia, despite actually what we have actually seen this morning, is still not having actually digital records. I would like to ask actually each panelists to give their comments on how we can actually accelerate the actual embracement of these digital technologies, because, I mean, taking into consideration the costs and priority, what are your advice in this regard? Because if we do not have actually the tools to capture the data, well, whatever exciting things that we are seeing here today may not happen as quickly as what we would like to see in some countries. What are your comments?
Hi, Yongkek. Thanks for asking that very important question. Maybe I can just chime in here. I think there's a tremendous opportunity now for countries who have not yet embarked into electronic medical record transformation. I can at least speak for Singapore. We have been doing this for the last, I would say, 15 to almost 20 years. And the challenge really is that standard electronic medical record systems are very heavyweight. They are very large systems that have been validated for many years. There are many good things to be said about these large electronic medical record systems. But I think what we are seeing here is that there's a move towards cloud-based electronic medical records, because that gives you the kind of integratability with things like mobile app systems. So one of the biggest challenges with current institutional-based electronic medical record systems is that they are built for institutions, not built for the patients. They are built with billing and process in mind, not built with data collecting and improving patient health outcomes at front center. So an example of that would be, there are a couple of these electronic health record systems that actually have mobile app functions, but most of those functions are curtailed in a way that they only allow the users to access certain functions. And certainly the hospital or the healthcare systems don't have the flexibility of building in new services and new systems as and when they want. The other point I want to quickly make is that I think that there definitely has to be a move towards the cloud-based systems to be able to integrate with many of the services that are now, modern services that are now available to mobile phones, such as apps and chatbots. So I'm particularly passionate about chatbots because I think that that's the way people would want to communicate with their clinicians in the future, rather than, again, turning up physically in the clinic, or even using video teleconsultations, because not all questions need to be answered immediately. And certainly the chat interface is something that people are very familiar with popular messaging apps. So I think that's a tremendous opportunity for countries who have not yet gone in electronic medical record systems to consider a cloud-based approach. Thanks.
So I would like to give my opinion, because if the United States is we can say that it's the most country using an electronic medical record because it's mandated by the government, really. So it was not an option for any healthcare system to exist without an electronic medical record. Having said that, we all hate our EMRs. There is no perfect EMR. It's not just being not cloud-based. The EMRs were done for certain purposes, right? So for billing, for even the inpatient communication between physicians is problematic. And that's why now there is a new wave of what the EMR should look like. I think if a country doesn't have an electronic medical record, I wouldn't go to these legacy systems. These legacy systems has failed in what they can provide to the patient and the physician. And now you can see the government is moving towards opening these electronic medical records, like forcing them to talk to each other and freeing the patient's information. I think the movement now in the next 5 to 10 years will not be that the hospital owns the patient information, but the patient owns their own information. If we own our own persona on Amazon, on Facebook, we should own our persona in the healthcare. The healthcare should be an acute setting to fix something that we have, but we control our future. The new generation is very comfortable with the technology. I think the old healthcare system, legacy systems, are going to exist just so that we can keep a documentation. But with the new, last year, there was the new policy of opening the EMR and giving the patient access to their data and sharing the data in between the hospitals. I think why it wasn't cloud-based from the beginning, remember, these EMRs started 20, 30 years ago. We didn't have the security in the cloud or the faith that the security is good in the cloud. I think all the brains or the thinking thought process has changed over the years. All new technologies now are in the cloud. It's just a transition. If I've invested $50 million in my EMR, it's very hard to come and say, oh, change your EMR because it's not cloud-based or because it doesn't have that functionality. The movement is there. It's just, we're not there yet.
Yeah.
Yeah. Thank you very much, Prof. Gillen. Perhaps Prof. Daniel, your comment, please.
Yeah. Thank you very much. I think after listening to Prof. Gillen, I think at some point, probably as soon in a few months, I'll probably schedule a discussion with you. I think you have a very, very thorough vision on how to best implement the EMR. Again, a very good one, Professor Gillen. So I think I would like to actually add on the first question, if it's possible. I think so. A key lesson that emerged during the COVID-19 pandemic was that leaders, such as policymakers and also the clinicians, physicians, they did not have the information as they needed to actually guide the complex decisions, especially in a very populated countries like Indonesia, around the management of the pandemic. I think I would like to add that one. And I'm talking about the EMR, Professor Gillen, in Indonesia, it's actually quite different. Probably in the US, you already started about 20 to 30 years ago, which is switching from the conventional medical record, writing medical records with EMR. In Indonesia, I think we just started less than 5 years ago. So the challenges are quite different. It's actually how to change the culture. That's the first one. The second one, but we are actually glad the Faculty of Medicine, University of Indonesia, have this special unit called the Indonesian Medical Education and Research Institute that actually now developing a cloud-based electronic medical record to gather all the clinical data. One of the biggest possibilities in Indonesia is actually we have a lot of data, but we actually need to say that not many doctors or healthcare workers and probably leadership understand how important the data. So the challenge in Indonesia is a bit different than all the major countries in the world, as you mentioned, Professor Gillen. But again, we're actually doing, even though this is a baby step, but I'm sure in a years to come, new generation, they are more acceptable with technologies. And now currently at my hospital, we are already transforming the electronic medical records. And also, hopefully we are in collaborations with IMERI, Indonesian Medical Education Research Institute, to use a cloud-based EMR like what mentioned by Professor Ki Yuan. I think that's all. Thank you.
Okay, can I just ask regarding, well, at one hand, we are saying that actually there are issues actually related to adopting digital technology, and then we say that actually perhaps also the patient-generated data could be captured. Could I ask actually Prof. Paul, your comment on the patient-generated health data, how useful it is in healthcare, and how AI could actually utilize this information? Because at the moment, most of the data generated are healthcare professionals' notes rather than patient-generated health data.
Yeah, thanks. I mean, I think how many of us have a smartwatch on, right? You know, monitoring our SATs, we can do EKGs with it now. It tracks our mobility. People are entering their diets. You know, but again, as Daniel said, there's a lot of data. We need to translate that data into usable information, and that's the tricky bit. And finding sort of simplified, standardized ways of doing that. I mean, for me, you know, patients, would have to come into the doctor, travel a long way just to get their blood pressure checked and the medicines renewed. Why? I mean, they can do their own home blood pressure monitoring, send that into a system. It can be analyzed by AI to say whether or not there's a problem. It can automate the refill of the prescriptions. It's tricky because doctors want to get paid, though. Yeah, that's that's probably the biggest obstacle is remuneration. But I think increasingly in a place like Singapore, we're moving to a model where fee for service, to capitation, where basically you're getting paid to keep people out of hospital. So you're moving from being a medical care system to a healthcare system. And that's a fundamentally different change that I think all of us are going to have to deal with, because healthcare costs are increasing far faster than GDP in any of the countries on this call. So unless we're finding creative ways to do that and use patient-centered monitoring as one component of that equation, we're not going to drive down healthcare costs.
Yeah, Paul, I can speak to that a little bit. Yeah, I think one of the greatest challenges is how do you then correctly incentivize providers to provide the best care for the lowest cost. So one of the initiatives that we've launched in a couple of years was something called value-driven outcomes. So we want to standardize costs across many classes of treatments, and clinicians are supposed to follow a particular kind of workflow. I think these are early steps towards the capitation model. Capitation itself is a very difficult model to implement successfully across entire healthcare systems. But that said, I think one of the key things we have to solve is to address clinicians and providers' habits and ways of doing things to improve the way we look at cost efficiency.
Okay, I think we have come to the end of this forum. I'm sure that you have many more questions to ask. Unfortunately, with the constraint of time, we just have to close this session. I think you would agree with me that we have a very interesting discussion this morning on digital technology, particularly on how the AI can be built into the background, especially in the cloud server, and how much actually wonder it could actually produce. The future certainly spells great promises, but I think at the same time, we are also encountering big challenges, particularly for countries that are not so well developed or financially limited in embracing and adopting the technology. So I would like to take this opportunity to thank all of you, the panelists, as well as the participants out there for sparing your precious time with us and taking part in the interactive discussion. So with that, I would like to pass back to the coordinator. Thank you very much. Hope you have a good day and continue to enjoy the meeting.
Thank you.
Thank you all. We have sent in the chat the link to the next session on medical education, and we hope you will join us then. Thank you, panelists.
Thank you.
Thank you.
Thank you very much.
Yes.
Okay, see you.
Thank you.
Bye.
Bye.
See you. Cheers.